All right, guys. So this is the second lecture on autoimmune diseases. So only the ones in blue today we're going to cover, but I wanted to put up this list because I wanted you to understand how many autoimmune diseases there are. A lot of these autoimmune diseases we're going to cover in other chapters, like for example, when we get to vascular issues, we're going to cover giant cell arteritis. Or when we get to GI, we're going to cover celiacs. And then look at the number one autoimmune disorder we're not even covered today, it's thyroiditis. So when your thyroid gland gets inflamed or sometimes destroyed. So we're going to cover most of these throughout the course, but I just want you to appreciate how prevalent the autoimmune diseases are and they affect every organ system. The ones we're going to cover today are kind of like the prototypical ones, the ones that kind of attack a lot of organ systems. So they're not really, it's sometimes I would say the ones that are hard to classify into one group, right? So we'll start with kind of what I think is like the hardest one, which is SLE. Okay. And SLE stands for systemic lupus erythematous. It's chronic. So, goes on slow, goes on long, lasts your whole life. And it's a systemic, meaning affects all organ, not all, but most organ systems. Okay, flares, remissions. There's probably some epitope recycling here, whereby as time goes on, you're just getting more exposed to antigens, like we talked about at the end of the last lecture. It's female predominant, most common in African American Hispanics. Now the thing is, it's Dr. Sattar had mentioned that he thinks most autoimmune diseases are female specific because of estrogen, right? And we covered that last lecture. But when you're a child or when you're really old, estrogen really doesn't. It's not important to your physiology as much as when you're, a regular adult. So that's why it's only 2 to 1 when children, old people, but 10 to 1 when it comes to females to males having this disease. Okay, as adults. So the main pathology is antigen antibody complexes being deposited into your tissues everywhere. So you make bad antibodies that you shouldn't be. They bind an antigen that's native to your body, and they deposit themselves. Um, and then also you have activation of complement, which damages tissues. Okay, you get decrease in C3, C4, CH50 because sometimes you have so much of these antigen antibody complexes. You need complement to uh, the body will use up the complement to try to degrade these antigen antibody complexes, and that's why you have a decrease in the complement. You just use them up, and then you have a decrease in your CH50 test, which tests C1 through C9, and basically it tests your ability to lyse RBCs if you need to. Um, so let's talk about the basic principles of how SLE can sometimes get started. Remember, we always mention that you need a trigger. If you have the genetic predisposition, doesn't mean much, but if you have a trigger and the genetics and the family background with the trigger, then you're in trouble, right? So in this case, SLE, unfortunately, one of the big triggers is UV light, which is the sun. The sun hits the epidermis, which is the outer layer of the skin, and it hits a particular cell called the keratinocyte. Keratinocyte is where melanin is stored, not produced. Not relevant right now, but just want you to know that keratinocytes unfortunately undergo apoptosis when they get hit with this UV light. Then obviously the debris makes up something called apoptotic bodies. Most of the time, this is eaten up by macrophages, but sometimes some of it gets missed by a little bit, or sometimes the B cells get to it. Now, if this apoptotic debris is taken up by a self-reactive B cell, okay, a B lymphocyte, that's not good. The self-reactive B lymphocyte, remember, that's the bad boy B cell. That's the one that escaped primary, secondary, and Treg. That's he got past a lot of checkpoints there. And on top of that, now he's picked up an apoptotic body, and it contains nuclear antigen, right? So now, unfortunately, it's going to start be like, well, this is foreign, this is bad, and it's going to start making antibodies against nuclear antigen, anti-ANA. All right. Now, step two. Now, let's say you get re-exposed to the trigger. Now, you get more the second time you get hit with sunlight, which might be like just a day later or 2 days later. Now, again, you're going to undergo the same process. Keratinocytes undergo apoptosis. You get apoptotic bodies. However, now you have antibodies against those apoptotic bodies, which contain nuclear antigen. So now you're going to form antigen antibody complexes. But at this point, still not so bad. You just got a few antigen antibody complexes. Maybe you have mild SLE, right? But bad news comes again when the dendritic cells now take up these antigen antibody complexes. And then this activates on their surface the toll-like receptors. And then this activates more of your bad boy B cells, your self-reactive B lymphocytes. And then now they make even more antigens, or sorry, more antibodies. And now those antibodies now bind more of your apoptotic bodies. And now you have more and more and more and more antigen antibody complexes. So so first you got apoptotic bodies, you made some complexes that you shouldn't have, but now it's circled back, and the immune system just went a little wild, and now you have way too many antigen antibody complexes. Now, unfortunately, some now normally, let me backtrack a second. Normally, these antigen antibody complexes they last for a while, but then the body uses the classical complement pathway system to get rid of them. But now let's talk about the poor souls who have issues with their complement um, pathways. Some people have early complement deficiency. It's a genetically that's what they have. So they have a deficiency in the classical pathway of complement proteins, especially C1q, C4, and C2. C2 is the most common, and 50% of these people will develop lupus. Okay, um, and uh, so another way to look at it is now these complements were used to remove apoptotic bodies, antigen antibody complexes to these apoptotic bodies, but now you can't even get rid of them. Your trash. This is your trash man, and your trash man is no longer picking up the trash. Okay, so what happens here? Um, the C1 binds to the antigen antibody complex. All right, look under the normal pathway for removal here. So C1 binds the antigen antibody complex, which then forms activated C1 that cleaves C4 into C4A and C4B. C4B, uses magnesium as a cofactor and cleaves C2 into C2A and C2B. C2A joins up with 4B and C1, makes a C3 convertase, and which then cleave C3 into C3A and C3B. C3B is an opsonin, right? So it helps, remove stuff. So C3 binds to the antigen antibody complexes, and then they get removed by macrophages in the spleen, and sometimes the erythrocytes, the RBCs, have a CR1 receptor that binds this complex, and then they take them to the spleen as well. So you just have to write down this normal pathway if you guys don't remember it from immunology. But basically, imagine if you were missing some of these complements. You can't remove these antigen antibody complexes. And so not only have you made too many, but now you can't remove them. And so you're going to have a severe systemic disease. The more things that are wrong, the worse your disease is going to be, obviously. So these are the diagnostic criteria. Fever, weight loss, fatigue, lymphadenopathy, Raynaud's. These are common in a lot of autoimmune disorders. I mean, your immune system is revved up, so you're producing a lot of cytokines like interleukin 1 and things like that. So obviously, you're going to have fever, fatigue, weight loss. Okay, that's just normal. Raynaud's, that's when your skin, your fingers change colors. Um, and Raynaud's, you're going to see that word all the time. It's associated with a lot of diseases, so really not specific to SLE. I do recommend you watch a video on YouTube about Raynaud's. It basically your skin starts off as white, as you blanch it, then turns blue if you lose blood. It becomes slightly ischemic for a second, then goes back to being completely red. So, all right, so those are very non-specific. However, these are the ones that are basically part of the criteria to diagnose SLE. You need about four. You need four things off of this. Okay, and we'll kind of start with the most important. So the malar butterfly rash or the discoid rash, especially upon exposure to sunlight. That's on the top here, the top two things that you see here. That woman with the rash that goes across her nose on both sides of the face. Doesn't always look like that, but that's kind of generally what it looks like. The discoid rash, which is classically called a lupus rash, clear white area, red erythematous area, and scales, almost like sometimes you see people with eczema or psoriasis. All right. And then the next criteria is oral nasopharyngeal ulcers. They're usually in the mouth, inside the nose, and they hurt. Arthritis, obviously your joints can flare up. Serositis, you can get fluid around the heart into the lung. If the fluid, we're going to talk about in the lung and heart chapters about what happens if you have too much fluid around the heart and lung. This can lead to some bad things. Psychosis, seizures. Unfortunately, a lot of times these clients can have altered mental status, be hallucinating. uh, visual more so than auditory, right? Um, and and that's kind of, you don't have to remember that, but that's something kind of cool to know. Renal damage. I'm going to show you photos here in a second, but diffuse proliferative glomerulonephritis, membranous glomerulonephritis. Just say these words out loud repetitively because they're going to come up again in the renal chapter. But one of them, the first one, is a nephritic syndrome, so you're leaking blood into the urine. The other one is a nephrotic syndrome, so you're leaking protein in the urine. But if you haven't heard these words before, this is all very confusing. Diffuse means it's everywhere. Proliferative means, it's expanding. Lots of cells are coming in. Glomerulonephritis, right? And itis means inflammation. Glomerulo of is the glomerulus nephritis, so kidney glomerulus infection. Membranous glomerulonephritis. I'll show you a photo of how that looks, but that's a nephrotic syndrome. Nephrotic means PHRO. If you see that in there, that means you're leaking protein into the urine. Okay. Again, I'm not going to test you on this test probably, but when you get to kidneys, I want you to remember this. That's why I'm saying this over and over, because these things are going to come up a lot. Okay, SLE, the next criteria is anemia, thrombocytopenia, leukopenia. If you're making, and that's because it's a type 2 hypersensitivity, right? So you're making antibodies directly against them. SLE is, remember, SLE, it's a 3 letters, type 3 hypersensitivity, but this is the one component of it that's actually a type 2 hypersensitivity. Lehman-Sachs endocarditis comes up as a test question. I've never seen it in real life, but basically, now that we have treatments for this, you don't ever see it anymore. And it's basically vegetations on both sides. So you can see this photo here with the 2 arrows on the heart on the left. Those are vegetations. They're on both sides of the mitral valve, which is in the left, between the left atrium and the left ventricle. Um, that's good. Okay, so moving on. So now let's talk about the antibodies. And again, these antibodies are actually part of the diagnostic criteria for SLE. So you get anti-nuclear antibody, which are very sensitive. Okay, anti-double-stranded DNA and anti-SM are very specific. Okay, uh, anti-double-stranded DNA is actually very important for clinical practice. Sometimes if they're about to go into renal failure, this is the one that we'll check. We'll get the titers on this. Having anti-nuclear antibody just is sensitive but not specific, so checking that is kind of useless once somebody already has a diagnosis. um, and then a lot of people will also have and the next criteria is antiphospholipid antibody. So these are antibodies against proteins bound to the phospholipids. So you can have anticardiolipin, lupus anticoagulant, anti-beta 2 glycoprotein 1. And these are important because they all kind of have different things that can easily be tested, right? Anticardiolipin, um, it 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 reacts, basically. It gives you the same. It gives you a false positive test when you're checking for syphilis, because these are the same. It reacts false positive with VDRL and RPR, and these are components that we check for when we're doing screening for syphilis. So your patient might not have syphilis, but they may test positive for it, and then you got to do a confirmatory testing, which actually then shows that they don't. Lupus anticoagulant. This is important. It gives you a falsely elevated PTT, and then that, in your mind, elevated PTT should equal thin blood. You're not going to make a clot, but it's falsely elevated, meaning that it could totally give you a clot. And I think this leads to the next slide right here. APA syndrome. This is really important. I'm an ER doctor. This comes up quite often. If I see somebody with lupus come to the ER and they're like, let's say they're short of breath, I'm thinking, oh my God, they might have a clot in their lung, right? Because lupus, a lot of patients with lupus have lupus anticoagulant, which causes antiphospholipid antibody syndrome, which is a hypercoagulable state, meaning you're gonna make clots, right? So deep vein in your legs, you see people whose legs swell up. That's they got what we call DVTs. Those can break off and travel, go to the lung, kill people. When you hear about a lot of times young people who die in their sleep, you're like, hey, he was only 25. He woke up not, he just woke up dead. He was completely healthy. A lot of times those are PEs. So pulmonary embolism, I should say. Um, and then you can also get clots in the hepatic vein thrombosis. So if that's an ultrasound finding. Placenta. So people, unfortunately, these women might have miscarriages and get clots in their placenta. And then cerebral thromboses. brain. And then obviously, when you have something like this, it's very dangerous to live with this. So you get lifelong anticoagulation. So when somebody comes in for the first time and they have a clot in their leg or in their lung, we'll do what we call a hypercoagulable workup. We'll figure out why they're clotting, and one of the things we're checking for is antiphospholipid antibody. Okay. Sorry, I took a long time on that. It's near and dear to my heart. Um, it's very dangerous, and it's something that if you guys are working in the field, you will see and deal with. And I put this chart up. This is from Robbins because it has all of those things that Dr. Sathar talked about in one spot. Um, at the bottom, you'll see multiple nuclear antigens, generic ANAs. All right, anti-ANA antibody. Remember, very sensitive, not specific. So almost 100% of patients who have SLE are going to be, have this, but just because you have it doesn't mean you have SLE. Okay, because a lot of other diseases you can have this, or sometimes you can have this and you don't have any diseases. The double-stranded DNA we talked about, and that's specific for nephritis, so kidney, right? We talked about anti-Smith, again, that's very specific for SLE. The phospholipid protein, anti-PL, we talked about just right now. And so, but the two things we haven't mentioned yet, and we're going a couple of ones that we're going to mention, U1 RNP. That's also that one is kind of cool because it's in the last disease we're going to talk about, which is the mixed connective tissue disorder, and Rho SSA nuclear protein. That's something that's present in SLE and Sjogren's, and we're going to talk about Sjogren's after this disease. But keep that in the back of your mind. Okay, it's going to come up. I just wanted to show you these photos from Robbins just because I think they're going to come up on board exams and a lot of things. Basically, this one, look at the bottom photo. That's the one that I care about the most. Has immunoglobulin. That's an immunofluorescence micrograph that shows IgG deposits along the dermal, which is in the black area on top, and the epidermal junction. So that a green line that's kind of snaking through, that's the junction between the epidermis and dermis. So if you're going to be, when we get to skin, that's going to be an important area of the skin as well that you're going to talk about. So if you see this photo, you got to think lupus. It comes up on. I've seen it on board exams in the past. This is kidney stuff. Um, Again, we're going to discuss this in detail when we get to kidney, but I wanted to show you this now just because repetition is key when it comes to pathology. The top left is focal proliferative glomerulonephritis. Basically, this is a cross section of your glomerulus. And so it's focal, meaning you see those two areas that I have pointed out. I drew out these lines because those are called necrotizing lesions. So this glomerulus is inflamed, okay? And it's leaking and it's got two necrotizing areas. Now go over to the other side of it, diffuse proliferative. The whole area has increase in cellularity, right? So that one's inflamed, but it's got cells everywhere. Now go to the bottom. There's something called lupus nephritis. You see these like little. It almost looks like dark little squig lines. They call them wire loops. They represent subendothelial deposits of immune complexes. The picture right next to it, it's an electron microscopy version of the same thing. I'm pointing out the basement membranes and also the subendothelial deposits of the same immunocomplexes. All right, so last few things about SLE. There's also unfortunately a drug version of this disease. That's something you guys probably haven't heard of before, so let me explain. Let's say you get I don't know, a heart attack, right? Everybody knows what a heart attack is. You can get a heart attack because your blood vessel is, blocked, right? But you can also get a heart attack if you take cocaine, and then that can give you a heart attack too by vasospasm of the arteries, right? So same disease, myocardial infarction, aka heart attack, but caused by drugs and caused by innate genetic factors. Okay, um, same thing with lupus. SLE can be caused by your genetics, like we just talked about, or it can be caused by you taking a drug. Now, unfortunately, these drugs that are on this list, hydralazine, propanamide, isoniazid, these are usually prescribed drugs; they're not abuse drugs. But when you give people these drugs, you have to be mindful that they could develop SLE, and you have to give them proper precautions. And if you're going to be a primary care doctor, you have patients chronically on something. Keep an eye on them. Check them for think about if they're developing SLE. And these are going to be anti-nuclear ANA positive, anti-nuclear antibody positive. they rarely involve the brain or the kidneys, um, and just taking away the drug takes away the disease. Okay. The treatment, avoid sunlight. We talked about the trigger and then the second trigger of the UV light. Okay, cool. Where's tinted SPF if you have darker skin, things like that. Glucocorticoids, those are steroids. Basically, you give them when this flares up. And then there's lots of other immunosuppressive agents that they can take. If you become a rheumatologist, you will know all about them. I am not one of them, so I can't tell you what they all are. And this used to be a pretty bad disease, I'll be honest. But now there's a huge survival rate. Now, this disease SLE is so vague. I want to give you some personal examples, so maybe it'll make it helpful to you remember. This disease can happen to anybody. Yes, we think about women, but I know a doctor it happened to. He was just getting fatigue. He didn't have a rash. He was just getting weird fevers. He couldn't get out of bed. He was sleeping all day, and he was like, in his early 20s, and he was in medical school. I remember, um, and then his kidneys started shutting down, and um, and then he went to the hospital. They couldn't figure out what was wrong, and it was only on his second or third visit they go, "Oh, wow, they diagnosed him with SLE." They did all those antibody testing and they figure it out. So remember, a lot of times a disease like SLE, which is very vague, very non-specific, it's going to get missed. So if you're an astute doctor, you're a smart doctor, you will pick up on this. Um, and the last thing I want to point about SLE before we move on, and this one is also important, I think, clinically, um, is this Rho SSA. Okay, I didn't specifically mention Rho SSA antibody just yet because it's going to come up in Sjogren's syndrome, but you can see here on this chart, it's part of Sjogren's syndrome and part of lupus. The reason this is important is because of pregnant women. Pregnant women who have SLE, you gotta check if they have Rho, also known as anti-SSA. Okay, Rho can cause or cross the placenta and go to the baby. This can cause congenital heart block and neonatal lupus. Congenital heart block, that's when the baby is born and they're very bradycardic, and obviously this can be very fatal, right? So if any of you guys plan on being OBGYNs, a pediatrician or neonatologists who go on to become pediatricians who become neonatologists, please remember this. Out of the 200 of you, I bet you 2 or 3 of you will see this, and maybe you will save a baby's life. So remember, um, Rho SSA is present in both Sjogren's and SLE. So if you have SSA, or if a woman has lupus, check her for um, check her for Rho. Okay, lupus, check a pregnant woman for Rho. Don't want that baby to die. Okay, Sjogren's syndrome. Let's talk about this. So I just mentioned the Rho. There's the antibody, but this is part of that. Okay. All right, so this one is classically characterized as the old woman with dry eyes, dry mouth. She has difficulty swallowing. She has really bad teeth because she's not making much saliva. Um, and she's got pain in her joints because guess what? Sjogren's syndrome patients also unfortunately, get rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disease of the joints. I also have you can see this photo I put up. This is an inflamed parotid gland. The parotid gland hangs out right here on the side of your face on both sides. There's actually glands that secrete saliva throughout underneath your jaw, back here, but the parotid gland is one of the bigger ones, and it can get swollen. Okay, if you have, and then also unfortunately these patients who have Sjogren's syndrome, they're increased risk for B cell lymphoma. Remember, if you insult something a lot, right, and you hurt it a lot, you're gonna get cancer there. A great example is, let's say you got a lot of acid reflux, you keep burning up the inside of your esophagus, and you get something called Barrett's disease. It's some repeated burning of the esophagus, burning of the esophagus. Eventually, one of the cells is going to make a mistake during mitosis and meiosis, and you're going to get cancer. Okay, so same thing here. Repeated inflammation of the parotid glands, you can get a B cell lymphoma. Okay, repeated injury. So at its heart, Sjogren's syndrome is an autoimmune destruction of lacrimal, which is tears, and salivary glands. It's lymphocyte mediated damage. So again, it's a type. So this time it's a type 4 hypersensitivity reaction, and this occurs with fibrosis. Okay, so remember, SLE type 3, but the anemia portion of it, thrombocytopenia portion of it, type 2, Sjogren's syndrome. So Sjogren syndrome, I guess, three-ish words or four-ish words, sorry. Sjogren syndrome. So 4 syllables, type 4 hypersensitivity. Okay. And then even patients without rheumatoid arthritis who have Sjogren syndrome might still test positive for rheumatoid factor. And that's just something that comes up on tests. Um, so Sjogren's syndrome characterized by ANA and anti-ribonuclear protein. Okay, anti-SSA and anti-SSB. RO-LA. Okay, so anti-SS Sjogren's syndrome. That's easy to remember. But then there's an A and B. It's also called ROLA. Okay, ROLA, ROLA, ROLA. RO is bad for infants. So RO, BOD, infants. I don't know why I remember that, but RO and then the big A, roll bad for infants. So if you see it in if pregnant woman has Sjogren syndrome, which hopefully it doesn't present that early in life, or has a lupus, remember you check her for ROLA, or sorry, check her for RO. Um, all right, Sjogren syndrome also has lymphocytic sialoadenitis. And this is a picture of a woman who's got an inflamed salivary gland down here. Remember, you don't just have the parotid, you got the submentals, you got the posterior, you have salivary glands all throughout here. Okay? So the point that Dr. Sattar was also trying to make is a lot of times when somebody has unilateral swelling of this gland, it's not infectious, it's not a block because of a small little stone, and it's chronic, you have to do a biopsy, and the biopsy will tell you if there's amyloid in there, if there's sarcoidosis, which is this granulomatous disease that we'll talk about when we get to pulmonary, or it could be a chronic viral illness. But you need to biopsy it. If the biopsy comes back with large amount of lymphocytes that you see in this photo, and you see this clear, like basically saliva secreting cells, then that's diagnostic for Sjogren's syndrome. Okay. Systemic sclerosis. Now let's talk about the next disease. Okay. These people unfortunately look like they just had way too much Botox. Now my wife is also a physician, and she has a beauty clinic. She does a lot of aesthetic medicine, and so she gives Botox. So I always tell her, this is what you look like if you get really bad Botox. Okay. You just like this. You're just looking like this all the time. Your just face is tight. This is tight, and that's when you have systemic disease, systemic sclerosis, the one that's throughout their whole body. There's a limited form and a systemic form. We're going to talk about both. But systemic, tight Botox face. All right, they look weird, unnatural, like they got some really messed up plastic surgery. Obviously it's an autoimmune disorder. Sclerosis of the skin and visceral organs. Sclerosis means scarring in a way, right? This usually, again, I put up pictures of middle-aged women here because it happens to middle-aged females. Okay. um, Fibroblast activation leads to deposition of collagen. That's kind of the pathway by which this occurs, right? Fibroblasts get activated, they put collagen in places it shouldn't go in, and you get issues. You get autoimmune damage to the mesenchyme. You get endothelial dysfunction. You get perivascular, so around the vasculature, fibrosis. So remember, the blood vessels, they have to be able to tighten, relax, but if they're scarred down, they can't really do that. And usually they're scarred down, they're so hard that you get hypertension. Obviously, if you you get organ damage, because sometimes the collagens get deposited directly into the organ itself, and you're messing up the blood supply to the organs. And remember, the skin is an organ, all these nerves are an organ, right? So you get issues within a lot of organ systems when you mess up the blood supply and you deposit collagen where it's not supposed to go. So Dr. Sattar did a drawing, but I kind of wanted to clarify it up and clean it up a little bit for you. There are systemic sclerosis obviously can have a few different ways that it can work. So first process is inflammation, right? So it's theorized that the endothelium and the connective tissue get damaged, right? And then what happens is, and a lot of times this is probably just due to, again, your type 4 hypersensitivity reaction. And then what happens is they express leukocyte adhesion molecules, which bind lymphocytes, which then translocate. You remember hopefully you remember from the previous lectures given by Dr. Mirza about this whole translocation process, and then those immune cells go into the connected tissue and cause inflammation. Okay, so that's how step one. Endothelial damage, in, increased expression of leukocyte adhesion molecules, cause the inflammatory cells to leak out of the blood vessels into the connective tissue and cause inflammation there. Second thing, you get vasoconstriction. When you have damaged endothelial cells, you get more endothelin and less nitric oxide. Um, Endothelin causes vasoconstriction. Nitric oxide causes vasodilation, so you don't want as much of it. You want less and nitric oxide, more endothelin if you want to cause vasoconstriction. This is actually a natural mechanism. I don't know if this is actually how this works, but this is how it's easy for me to remember. When a blood vessel is damaged, it doesn't want more blood to leak. Imagine if the hose gets cut, right? Let's say it's going to want to clamp down. So if the endothelin inside the endothelial cells get damaged, they're going to want to clamp down. And how they clamp down is they release endothelin, which is a vasoconstrictor, and they decrease the amount of nitric oxide, which is a vasodilator. So again, scleroderma causes this problem as well. Secretion of growth factors. As the endothelial cells get damaged, they release TGF beta, PDGN, prostaglandin-derived growth factor, PDGF. So TGF beta, PDGF. This activates fibroblasts in the connective tissue, and again, this leads to fibrosis, which causes vasoconstriction. Vasoconstriction leads to ischemia, which causes end organ damage and systemic sclerosis. So all three of these things, so inflammation, and vasoconstriction and secretion of growth factors all take part in this disease because it's a systemic disease. There's also what they call a limited type of this disease. Okay, so the limited type is just localized to a few little areas, and it's called CREST syndrome. So you know how we just talked about lupus, and lupus had this antiphospholipid syndrome, and it's very confusing. It was like a disease within a disease. I hated that as a medical student, but guess what? It is what it is, right? So now scleroderma, also known as systemic sclerosis, there's a limited type, limited time offer, and it's called CREST syndrome. CREST syndrome, and it's easy. Whoever named this, thank you. Calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. Okay, let's go through those real quick. Calcinosis, you can see on that thumb, on this hand, there's like a little area on the thumb. It's like a circle, it looks like. That's going to be where calcium is deposited. Okay, and then Raynaud's phenomena, we talked about that already. Esophageal dysmotility. This drawing that Dr. Sattar did, he talked about how the esophagus gets scarred down, right? A lot of either collagen deposition, inflammation, things like that. And peristalsis cannot occur. So if you think back to how esophagus moves, if let's say you eat a food item, this muscle above it squeezes, pushes it forward. Muscle underneath it relaxes, allowing it to go forward. If that ability to peristalse is impaired, you're not going to be able to swallow solids and liquids. Okay, solids and liquids. That's something that comes up. Sclerodactyly. That's when on your fingers. If you notice this guy, he has very beautiful fingers. Even if I'm not that old, but I still have, some lines over my DIP, distal interphalangeal joint. But this person, will have very few of those, and their hands are going to be a little like almost like tight, like claw-like. Okay, telangiectasia. You see these around the nose. You're going to get them on the neck, the face. You can get them on the body. They're just like little tiny little dilated blood vessels close to the surface of the skin. That you'll see. Okay, so that's CREST syndrome, a disease within underneath systemic sclerosis. It's a limited type. Now, the main type of systemic sclerosis, also known as the diffuse type, it's going to have way more problems, right? It involves the skin with early visceral involvement. It's going to not so let's talk about the skin for a second. In the CREST syndrome, I only showed you a photo of the hand because it only usually involves the hand as far as the skin involvement. Okay, but this one involves the face and the hand and other parts of the body, right? This one again, you're gonna have that face, like that tight face, right? Because again, you're laying down collagen in places it's not supposed to be. All right, you're scarring it down. So that's going to be the pathogenesis, and I'll show you a biopsy of the skin here in a second. Right here on the top here, that's normal skin and scleroderma skin, and under scleroderma skin on their face here, you can see the collagen deposition everywhere, right? And absence of appendages of hair, so no hair follicles. So this woman, I mean, granted, most women don't want mustaches, but I bet you she does not have a mustache. She does not have much facial hair. Um, and there's also a foci of inflammation right there in the scleroderma cell, or a scleroderma skin. And then let's look at their hands. This guy has claw hands, and he's his hand the disease has progressed so much he's losing blood supply to his fingers from the scarring of the blood vessels, which is causing ulcers. Ulcers are basically your skin that breaks down, and is chronically broken down and can't heal properly because you just don't have good blood supply. So you'll see this in a lot of old people, let's say, who got really bad diabetes and their blood's not flowing to their skin. You're going to see ulcers there, things like that. So this is unfortunately a really bad case. So so we talked about vessels. It's going to cause hypertension, Raynaud's, GI tract, esophageal dysmotility, and also this also has that. Lungs. I put this RIP, this tombstone next to it because this is the most common cause of death in people who have systemic sclerosis. They get interstitial fibrosis, meaning they get their lungs basically can't open and contract properly. And we're going to talk about that more in the lung pathology section. But I believe it's what we call a restrictive pulmonary disease, meaning it just restricts the opening of it. And then they also can get pulmonary hypertension. The blood vessels inside the lungs squeeze down, and that's called pulmonary hypertension. And that leads to, we're going to skip ahead for a second, to the heart. Because if the heart has to push against, the right side of the heart especially has to push against uh, a very tight blood vessels in the lungs, the heart, eventually the muscle gets thicker and thicker and thicker, and that leads to heart failure, which again, we're going to get to when we get to the heart section. And you can also get fibrous scarring in the heart section. The kidneys are also obviously affected. Sudden onset, usually scleroderma, they call it the scleroderma renal crisis, and you have to treat them with ACE inhibitors to quickly normalize their blood pressure. And this diffuse type is associated with DNA topoisomerase 1 antibodies, in addition to the Rho and the La. Okay, okay, we went over this already. By the way, these photos I think is very important. Please look at this photo. And the last slide is mixed connective tissue disorders. Dr. Sattar did a great job on this, but I'll just say that you just got to know what that U1 ribonuclear protein that's associated with. These people usually don't have renal or CNS involvement as well, and it's a mixed. So this is SLE plus systemic sclerosis plus polymyositis. Polymyositis refers to inflammation in your muscles in multiple areas as well, which again we'll get to in the skeletal section. Um, but yeah, guys, I know this was a lot, but look at this chart. You know, it's going to have some of the things that you need to know, some of the things that you don't. If I didn't cover the antibody specifically in the lecture, you don't have to know it. But again, this section is very vague. It's very difficult, but it just the more times you go through it, the better you'll get at it. All right, thank you so much, guys. I hope you enjoyed this lecture, and I'm going to keep my lectures like this. I'm going to make sure that they follow Dr. Sattar's lectures, but I'm going to add the photos and charts from Robin's that I know will show up, on board exams and that are just relevant. And the more photos, the better, right? I am a visual learner, so that's how I learn.